Great. So yeah, before I get started, I just want to say a huge thank you. For one, the idea for this conference comes from Lupus Warriors and other community partners of ours. I want to give a special thanks to the Community Advisory Board for Lupus Care and Research, who's been working with us since January of this year, giving us feedback on both resources and research activities that we have going on. I want to give a thank you to the speakers for taking the time to be here with us today. And then I also want to highlight Lupus Detroit, as well as the Michigan Lupus Foundation, who helped spread the word about the event today. This slide shows our agenda. We'll start with kind of a brief welcome, followed by a talk from Dr. Michelle Kallenberg on what is lupus and research gaps in lupus. Followed by that, we'll have someone sharing their journey as a lupus warrior. And then some other topics on nutrition and self-care for lupus, as well as navigating healthcare for lupus. And we'll wrap it up with a moderated panel discussion. So to get started, I just want to give a very short overview of the Chronic Pain and Fatigue Research Center, also known as the acronym CPFRC. This is the center at the University of Michigan that Kiana and I are affiliated with and helping to host this conference. So the CPFRC is a group of investigators and clinicians who study conditions that have chronic pain and fatigue as core symptoms. Some of the conditions we study include chronic lower back pain, long COVID, sickle cell disease, in addition to lupus. So pain and fatigue conditions can be difficult to treat, and what works well for one individual often will not work well for someone else. Therefore, some of our goals as a research center are to, one, understand the biological mechanisms that influence these conditions, two, to study the best ways to treat pain and fatigue, three, to provide customized interventions and therapies for everyone. Within the CPFRC, we're committed to health equity. Health equity will be achieved when every person can attain their full physical and mental health potential. And health equity is different from health equality. So you'll see the picture on the slide to the left where two people are reaching for apples in the tree. They both have equal access to that tree, so the same number of boxes, but one individual cannot reach the apples in the tree. And on the right, you see that this disparity is corrected, where the person who previously couldn't reach the apples in the tree is now given more resources, so they have equal access. Health inequities are avoidable, unfair, and unjust. The Health Equity Core is a specific unit within the CPFRC. Objectives for this core include increasing diversity, equity, and inclusion within clinical care, research, and intervention development for chronic pain and fatigue conditions. We also aim to facilitate bidirectional learning and resource sharing between academic and community partners. We know that research can move at a slower pace than the immediate needs of communities, so we're regularly planning community and education events where we can share information on self-care for chronic pain and navigating healthcare settings. For example, we're finalizing a curriculum for a free 6-session series on mindfulness and healthy eating. So if you're a part of a group or you know of a group who may be interested in learning about any of these topics, please get in contact with us so we can talk about how this group might host these sessions for its members. Health equity is important in the context of lupus because chronic pain conditions like lupus are more common and more severe among under-resourced communities and communities that face discrimination in healthcare settings. For example, if you're Black, you have a 2 to 4 times higher risk of developing lupus than if you're white. And the figure on the slide shows that deaths due to lupus are also higher among Black patients than white patients. As part of our work in the Health Equity Core and through collaborations with other speakers on the call today, we conducted a study to better understand the experience of living with lupus among Black and African American lupus warriors to put a spotlight on the perspectives and priorities of this patient community. Currently, we're in the data analysis stage of this project, and we hope that our findings will inform better standards of care and symptom management for patients. Some of our preliminary findings include that patients face many challenges when trying to get a diagnosis for lupus, and that every patient journey is unique. We also learned that patients could benefit from customized and comprehensive care plans that may include seeing a nutritionist or a therapist in addition to a primary care provider and a rheumatologist. Based on our preliminary findings, it also appears that there's opportunities to help educate clinicians, family members, and employers about lupus as a way to support lupus warriors in their day-to-day life. So before we get to our great lineup of speakers, I want to talk a bit more about pain and lupus. Pain, like lupus, can be invisible. When looking at the two people on the slide, can you tell who has chronic pain? On the left, you see someone with crutches, and on the right, you see someone standing upright without crutches. While the question may seem simple, looks can be deceiving. There really is only a modest relationship between injury and pain. So 30 to 40% of individuals with a joint damage or a broken bone injury don't have any pain, whereas 10 to 15% of individuals with very severe pain don't show signs of joint damage or injury when looking at an X-ray or other forms of imaging like MRIs. So research in pain science has revealed that there are 3 types of pain kind of contributing to this difference. The first type of pain is injury pain, also called nociceptive pain. This type of pain is due to things like inflammation, a broken bone, or a torn ligament. When you stub your toe, this is the type of pain we're talking about. The location of the pain is localized, so at one area of the body, and consistent. The second type of pain is nerve pain, also called neuropathic pain. This type of pain is due to things like nerve damage or a pinched nerve. It often refers to radiating pain that can be paired with numbness or tingling. The third type of pain, and the type of pain that people are usually least familiar with, is centralized pain, also called nociplastic pain. Nociplastic pain is due to heightened sensitization in the central nervous system. This type of pain is often widespread and in multiple areas of the body. It can also change locations. It's often paired with other symptoms like sensitivity to light and sound, frequent headaches or migraines, dry eyes and mouth, fatigue, trouble sleeping, problems with digestion, and brain fog, things like memory problems or trouble concentrating. It's also important to understand that multiple types of pain can be present in any condition, known as mixed pain states. For example, if you have chronic pain, regardless of what other conditions you have, whether it's lupus or diabetes, nociplastic mechanisms are likely a component of the pain that you have. Thus, mixed pain states can require using more than one treatment strategy to improve the pain. This could include non-drug therapies, which we will be discussing more today. Unfortunately, healthcare systems don't do a great job of treating chronic pain, and there's a number of reasons for this. So for one, even when inflammation is controlled, pain and other related symptoms can persist for lupus patients. Second, surgeries and pharmaceuticals are often prioritized based on the pay structure in healthcare settings. However, even the drugs with some of the best evidence for pain management only improve symptoms for about 1 in 3 people. And kind of expounding on that, insurance companies are just beginning to develop models that incentivize overall health and well-being as opposed to just surgical procedures. Another important point is that not everyone has a healthcare provider that they like and trust, and treating pain often requires multiple healthcare visits and trying a few different strategies for any one person. And finally, there's a huge burden on individuals to navigate healthcare and manage their pain-related symptoms. So people with lupus are challenged by the demands of seeing multiple specialists, taking multiple medications, and making significant lifestyle changes. A goal of today's conference is to help address some of these challenges by providing education related to lupus and living with lupus symptoms for both lupus warriors and the communities that support them. So without further ado, we'll jump into our next topic, which will be presented by Dr. Michelle Kallenberg.
All right, thank you so much, Rachel. Can everyone see my screen? I guess I'll ask Rachel. She has the power to speak.
Yes, I can see it.
Wonderful. Good morning, everyone. I'm really happy to be here to talk about, I think, some very important aspects of lupus and how we have the potential to sort of transform and change how we treat and think about lupus entirely. So I currently am an associate professor at the University of Michigan. I'm a rheumatologist, and I do a lot of research as well. I help to direct the lupus program at the University of Michigan, and I'm also an associate chief for basic and translational research. So I am a big advocate for research and using that to help us make a difference for patients with lupus. So I probably don't need to tell this audience how lupus can affect patients in many and different ways between patients. So, the thing that most doctors worry about is that it can cause damage to organs, and we can, develop long-term damage and scar in organs that can cause, difficulties with chronic illness down the road. But I think some of the other things that lupus patients experience that we're not as good at dealing with is that lupus can do other things. It impacts your ability to have and raise a family. It interrupts your work productivity. It leads to financial stress. Medications are expensive. Insurance companies don't want to cover drugs. You get bills for things you weren't planning on. Lupus disrupts sleep. It can cause stress and depression just from having a chronic illness, and then some of the changes that lupus causes on top. And lupus also makes you tired. So your coping skills to deal with all these other things can be less just because you don't feel well. And so, this is an important aspect because so much of the basic research that's been completed so far has really focused only on the first item, which is the organ damage aspect. And so I'm going to talk about a little bit about what is lupus, and then we'll move into talking about where we think research is important in these arenas. So when we think about what is lupus, actually, it's a combination of environmental exposures and genetic risk that work together to turn your immune system on so that it is fighting you instead of fighting infections. And we think that, there's many different risk factors for developing lupus. And here's just a list of genes that have been described. And the interesting thing about lupus, even though it runs in families and there is genetic risk, there isn't just one gene that's going to lead to disease. We call this polygenic, poly meaning many, that there's many risk factors that contribute to this disease. And just because you have one or two risk factors doesn't mean that you will get lupus. And the reason is we think that many of the risk factors that cause lupus actually have to be triggered in the right way. And so when patients ask me, why did I get this? Oftentimes I say it's a mix of your genes and bad luck. Because things like UV light exposure, infections that you happen to get at a certain time in your life, probably chemical exposures from the environment or from foods, lead exposure, mercury exposure. There's lots of different factors that have been identified that can put people at risk for lupus. And when those are combined with certain genes that give you different responses to these triggers, it can activate the immune system in the wrong way. And so once we kind of have this trigger, then the immune system gets miseducated. And we know that all the different parts of the immune system are important in developing lupus. We know that our early responders are what we call the innate immune system. They are hyperactivated, they overstimulate other cells. They die too frequently, and some of them die through a process called netosis, which causes triggering of other cells. And then what happens is those educate our T and B cells, which are what we call adaptive immune system. This is what makes our vaccine responses, gives us memory to fight off infections that we've had previously. And in lupus, this adaptive immune system, which consists of our T cells and B cells, starts to attack our own body. The T cells can directly kill various cells in our organs, and the B cells make antibodies, which can go to our organs, bind in the organs, and cause what we call immune complexes to form. And those can damage the tissue, and then they bring in other immune cells to further damage the tissue. And these autoantibodies, you might have heard of some of these, what we call the ANA test for lupus. That is a very generic screen to look to see if you have antibodies that recognize anything that lives inside a human cell. But there's more specific ones, which you might have seen on some of your testing, things like anti-Smith, anti-Ro, anti-La, anti-double-stranded DNA. All of these autoantibodies have different functions in terms of the complications that they cause with lupus. For example, we see a lot of skin rashes in patients who have anti-Ro antibodies, and we see a lot of kidney disease in patients who have double-stranded DNA antibodies. And so, once the immune system gets turned on, and this can happen 5, 6, 7 years before you actually have manifestations of disease. We know in studies from the military that you can have autoantibodies present, up to 10 years before somebody develops lupus. And so probably it's an additional trigger that actually pushes patients towards disease. And that's where you get the rash, the worsening fatigue, the joint pain, the kidney inflammation, pain with breathing, all the other symptoms that patients experience with lupus. And then long-term with lupus, the other thing we know is that every time you have a flare of lupus, it's sort of beating up on your body a little bit, and you can get this cumulative damage that occurs not only because of the lupus attacking organs, but also because of the steroids that we use to treat the flares. And steroids long-term are the #1 reason why patients accumulate damage. Of all the other things, steroids are #1. So we're really trying hard to figure out how to get away with less steroids in our lupus patients. And just to highlight some other things that we worry about in patients, cardiovascular disease risk long-term is also an issue. And that's probably because of the chronic inflammation that patients over time. And like I mentioned, there is sort of this life cycle to autoimmune disease where patients start with a risk. And then I like to think of the triggers as kind of like a light switch where they can turn the activation of the immune system on or off. And when that light switch gets activated, patients have a flare. They get the organ damage, they get the rash, they get the arthritis. And then what we currently have to do is we come in and basically suppress the immune system. And I think of this as using a hammer because we're kind of, especially with steroids, we just whack the immune system down and, try to get things calm enough and then hope that it doesn't flare up again. And we use other medications to try to prevent that. But we all know that all the medications that we have side effects. There's nothing that we prescribe for lupus where we don't give you a long discussion about all the things that come with taking that drug. Most of our medications for lupus increase risk of infection, and a lot of the newer drugs are super expensive. And so getting them approved by insurance companies and keeping the copays reasonable and affordable for patients becomes a major task for the physician's nursing team, and the patient. And so really where I think we need to turn our attention in lupus is to think about how do we prevent the flares from happening. And this could be either through working on the predisposing factors that contribute to lupus, or blocking the light switches, keeping the light switches from getting turned on so that we don't end up in this cycle of flare over and over again. And that's really one of the goals of my lab, is to really work on these triggers, especially UV light and how this affects the skin. So I wanted to briefly just kind of go through how our current medications for lupus work, because I think this is interesting and it shows a little bit about how we're starting to make a little bit of progress. And so some of our lupus medications I think of as a tuning fork, like they fine tune the immune system. And the one that most patients are familiar with is hydroxychloroquine, as this really is a standard of care drug. Everyone should be taking hydroxychloroquine unless they have a reason. They're allergic, they can't tolerate it, they've developed some toxicity from it, like retinal buildup of pigment, something like that. But what hydroxychloroquine does is it just kind of keeps the immune system from being so hyper responsive to the triggers that come at it. So infections, environmental triggers, it kind of just slows down that activation cycle so that you're less likely to respond and flare. And there's clear data that if you look at cohorts, there was one from Toronto where they took patients who had lupus nephritis and they kept them on Plaquenil and then until they were in remission, and then they took half of them and kept them on the hydroxychloroquine Plaquenil, and the other half they let them come off, and they just followed them over time, and the flare rates were much higher in the patients who stopped taking the hydroxychloroquine. And so we really think that this is a medication that really kind of calms down the triggers and keeps patients from getting sick. It doesn't always work, but it definitely helps. And then the other things that are fine tuners, and you'll hear about some of these today, are really important. Diet, exercise, sleep, stress reduction, all these things can aggravate or calm the immune system depending on whether they're used correctly. And so it's really important to always think about these adjunct treatments when we are trying to help a patient with lupus. And this is something that patients can bring up to their doctors about what other things can I be doing to help my lupus get better. So those are sort of the tuning fork things. And then we have the big guns, which are steroids, which just massively suppress the immune system. They kill off all of your T cells and B cells very rapidly, especially when used in high doses. They work very quickly. Patients feel great on them until the side effects kick in. So it's a love-hate relationship. We can make you feel better, but then the side effects of the steroids, weight gain, cataracts, bone loss, muscle weakness, irritability, mood swings, all the things. So, and then the other big gun that we use when we have really kind of scary lupus where the brain is inflamed or we have really bad kidney disease would be cyclophosphamide or Cytoxan. This also just kind of wipes out the immune system to kind of try to get it to start over. It also comes with a lot of side effects. And so these are things that, are used because we have to, but not because we like it. And then I like to think of the rest of our meds that we have for lupus kind of as smaller guns. So Cellcept, it's also called mycophenolate mofetil, Imuran or azathioprine, methotrexate, calcineurin inhibitors like tacrolimus. So these are kind of the same principle where they basically generally suppress the immune system, but they don't do it as aggressively as steroids or as Cytoxan. So they're kind of like mini suppressors, I would say, but they're still not very elegant, and they all come with a lot of side effects. You have to get your labs drawn to monitor, and then patients, sometimes don't feel well when they take these medications. Cellcept can cause diarrhea, methotrexate can cause nausea. So none of these drugs are perfect and where we want them to be. And then we do have a few newer medications that are more specific. They're not big guns anymore. They're sort of targeted. So we do have Benlysta or belimumab, which targets the development of B cells, which make these autoantibodies that can go in and help to damage tissues. A lot of patients like taking belimumab. It's either an injection you do once a week or it's an IV infusion once a month. And there is some good data that this can help prevent the long-term cycle of flares. It's very expensive. It's a biologic medication. But it is out there, and we've had it in our ability to use for about 10 years. And now it's also approved as an add-on therapy for lupus nephritis to improve rates of remission. So, that's been one improvement that we've had. Another one is anifrolumab, which was approved last year. And this one targets a cytokine called type 1 interferons, which basically help to flip the switch to overactivate the immune system. So by blocking the interferons, it also kind of calms everything down. And we see from the trials and some of my clinical experience, this medication is probably really good at helping the skin. We're not sure how much it's going to help everything else. And as we get more clinical experience with the medication, we'll know better whether this will really have a big impact for lupus patients long term. But despite all these meds, I really think, and I think patients would agree, that there's still too many patients that don't sufficiently respond to treatment. So when we just think about the organs, there's a 50% response rate for kidney disease to any of these medications. The arthritis in skin can be very stubborn. I see these patients in my clinic very frequently. We get lots of side effects from steroids still, and things like fatigue and pain and poor sleep. All of these things don't really get treated that well by these medications. If I have a patient whose fatigue improves with treatment, I do a big time happy dance, because that's not the usual case. And the other thing that we also don't have is we don't have a good prediction tool for what medications are right for which patients. And I'm sure all of you have been through the cycles of, oh, well, maybe we'll just try this one and see what happens. And then when it doesn't work, then we try another one. And that's because we don't have data or a good enough understanding of what is driving specific manifestations for which patients. And really, I think, patients and doctors both, what we really want to do is have treatments that work for the individual patient, so that when a patient comes in to our office and has, a disease, we basically would know, hey, you need treatment A, or you need treatment B, or you need treatment C. And we don't have to go through this cycle of let's try this one and then C, and let's try this one and let's see. We want to get rid of that and be able to predict which is the right therapy for the patient from day one. And the other thing this will help is to get medications approved by insurance companies much faster, because a lot of times, whether we choose treatment A, B, or C is driven by the insurance company and what they find acceptable rather than what we think is best for the patient. And so if we have ways to say this patient is going to respond to this drug, it'll be much easier for us to get the right therapy from the insurance company at the same time. So, all of these things really require us to do research, because we don't have the knowledge and tools to get us to this utopia where we can fix lupus from the beginning with as few side effects as possible and with as much efficacy as possible. And so I want to spend the last couple minutes of my talk just talking about the hope that is out there and where things are moving. So right now, if you go to the website called clinicaltrials.gov, this is run by the National Institutes of Health, and it captures all of the clinical trials that are ongoing in lupus right now. There's 176 open studies in lupus, and this is awesome. This is much higher than it used to be. There's a lot of interest because we've made a lot of progress in understanding the molecular mechanisms behind lupus. Besides, let me see. Yeah. Besides just, what we think of classically for these trials as, you get this drug and see how you do, it's not just about the drug trials. So there's a lot of patient registries where patients can sign up and just be followed, and they can answer questions and talk about their experiences of having lupus. There's observational cohorts and biobanks where patients can donate blood or skin or other parts of their lupus to follow and contribute to biobanks, so we can look at treatment responses and behavior of lupus over time, how side effects correlate with certain features within the body. Lots of information can be gleaned from these observational cohorts. And then, of course, we're also doing research to try to understand how to make the experience of lupus better. Non-drug interventions such as acupressure, diet trials, physical therapy, and as Rachel was mentioning, understanding pain and how to best improve pain in lupus patients as well. And right now, there's 110 interventional trials in lupus in the United States that are currently enrolling. And this includes drug studies, but also things like, does acupressure improve chronic pain? Does meditation improve sleep? So there's a lot of research ongoing to look into this. And in the lupus drug world, where we're trying to get better medications to patients, there's lots of different things in the pipeline. So drug trials have to go through many different phases. So first they have to do safety trials, which are called phase 1 trials, where they make sure that the medication doesn't, cause bad side effects, other things. And then they go to a phase 2 trial, which usually involves a couple hundred patients, and they study to see whether there really is, hope for this drug working. And then once they have that data plus more safety data, then they go to phase 3 trials where they recruit in hundreds and hundreds of patients. and look to see how that improves patient health with that particular trial. So right now there's many different targets that are in phase 3 studies right now. So I think this is really exciting because hopefully we'll get more and more medications available for us to use for patients. And there's some others that are coming into phase 3 studies as well. And I just wanted to highlight this CAR T idea because I've gotten emails from a lot of patients and I think it's very exciting. This is data that was published in Nature Medicine, which is one of the top medical journals, maybe the top, a couple of months ago. And this was a study where they took 5 patients who had really refractory disease. These patients all had still really active disease. This is measured by a metric called the SLEDAI. So when the SLEDAI is above 6, patients we think of as pretty active. That means they've got at least 2 active organs involved, plus, blood markers of disease activity. And so these patients had all been treated with things like Cytoxan or methotrexate or Celcept. And almost all of these patients had a history of kidney disease. And these patients go through a little bit of a chemotherapy conditioning to kind of suppress their bone marrow a little bit. And then what happens is they take T cells out of the patients, and then they transform those T cells into ones that can go back and recognize B cells within the patient, and they go in and kill those B cells. And it lasts for a little while, and then eventually those CAR T cells go away. And here, the exciting thing is that every single patient in this study who got this CAR T cell therapy improved. We saw their markers of lupus improve. We saw their fatigue improve, which was really quite surprising and remarkable. And this seemed to last for up to 6 months, even after the CAR T cells had gone and the B cells started to come back. Now, this is super exciting. This is a very complicated procedure to do. It requires specialized centers that know how to make these CAR T cells. And it's very expensive. It's like $100,000 per patient to make these CAR T cells. But there are companies who are currently working to make this technology cheaper and better. And there are more studies that are coming down the pipe to study this in lupus. I know we've been contacted a few times by some places that want to do this study in lupus patients. So I think, again, the research is really showing that we are probably on the cusp of really being able to make some big time differences, especially for patients who haven't been able to respond to current therapies. And I think really the last thing I wanted to emphasize is that in order for this research to happen, we need patients. There's so many companies interested in testing drugs in lupus patients now that they're kind of using up all of the patients that have sort of been willing to do research so far. And what we need is more patients who are willing to participate in this research process. And it doesn't just have to be drug trials. If you want to see what drug trials are out there right now, I highly recommend that you check out the Lupus Therapeutics website, which is a branch of the Lupus Research Alliance. Lupus Therapeutics vets all the clinical trials that they support to make sure that the safety looks like it's going to be good for lupus patients, that the mechanism makes sense. And so they only bring trials to out there lupus sanctioned trials if they feel like it's safe for patients and it's going to be a good idea. So full disclosure, I sit on their vetting board where we look and see if these trials are good. So but here you can look and see where are the Lucin sites and what trials are up and going. And University of Michigan is a Lucin trial center. And so if you do have any interest in getting involved in research, we've got a lot of things going on in the lupus program at the University of Michigan. We've got lots of different kinds of studies. So you can do research in many, many ways. We do have longitudinal cohorts that are for patients with systemic lupus or antiphospholipid antibody syndrome or both. And patients can participate just by, donating blood. For a lot of the lupus patients, we ask for a skin donation. It's It's not required, but because we also are very interested in studying the behavior of lupus skin. With these cohorts, we're looking at what we call disease heterogeneity, like what are the differences between a patient with a rash and a patient with a rash, because we know that all rashes are not created equal, and also the way that the patients respond to therapies are not equal. So we need to figure out what is different between each patient. And then also we're looking at how patients respond to medications. And if they respond to a medication, what got better? If they didn't respond to the medication, what didn't get better? And that might tell us about what additional pathways we need to think about and how we could rationally design things like combination therapy, for example. We also have proof of principle trials ongoing. One example is we have a current open trial looking at prevention of photosensitivity using a medication that is already approved for rheumatoid arthritis. So we're actively recruiting patients for that study. We also have patient advisory boards, as Rachel was mentioning. The Lupus Community Advisory Board has been really an amazing group of women who have contributed their experiences and also given advice on how research, can better reach marginalized communities and underrepresented communities in lupus research. And we really have a goal of increasing the presence of all different types of lupus and backgrounds and diversity of lupus patients in our studies. We also have, non-drug intervention trials, things like acupressure, studies looking at alternative pain control methodologies. We've been trying to get some diet studies launched. We're still looking for funding for those to look at diet interventions, for example, but there's a lot of things happening. And then, like I mentioned, we are a Lucent site. We're going to be enrolling very soon for a medication that's an oral medication that looks really promising from the phase 2 studies that will be for patients who have active disease. And there's also the same study for the same drug for patients who only have cutaneous lupus. So if anybody has any interest in doing research, this email here is to my lupus research coordinator, and you can just give her your name and she can reach out and we can see, what you would be eligible for and how you could participate. And we also need healthy control. So if you have friends who want to support lupus research and they are lucky enough to not have autoimmune disease, they can also help the research process by being a healthy control sample. So we have people to compare to. And so if you've got friends that you want to sign up for it too, please reach out to us. We'd be happy to talk with you guys and see what you're interested in doing. And so with that, I just want to say really, together, we can make a difference. This is just a picture of all the people that work in my research group. Yeah, if you have questions, please feel free to reach out. I'll be happy to take questions at the end when we do the Q&A.
Thanks so much, Michelle. And I do see a question in the Q&A now if you want to answer live, but we will also be taking more questions at the end. And next up, we have Tiffany. Tiffany, please feel free to use the full 20 minutes. If we need to eat into the moderated discussion a little bit, we can. So I'll mute myself now and we look forward to hearing your talk. Oh, we can't hear you, Tiffany. I don't know if it doesn't look like you're muted, but I'm not sure. No, cannot hear you now. It may be possible if you need to call in, there should also be a call-in number that we could possibly get audio for. Can you hear her? Can other people hear her? Sorry, maybe it's just me.
No, I can't hear either. I was gonna ask if Tiffany can, I don't know if it'll help, maybe if you try your video off and on really quickly.
Can you hear me?
Yep, now we can.
We can hear you now. Excellent.
I picked
We
the
got
wrong
it.
one.
No worries.
There's like 3 options and they all say the same real tech. I'm like, sorry.
Great. All right.
But my name is, sorry, here we go. Let me move this. My name is Tiffany Stokely, and I'm going to talk about my lupus journey in hopes to encourage and inspire others, and also to provide just some insight into what it's like being a lupus patient. So I'm gonna start from the beginning. I go through the whole journey. So as a young child, I was always tired and I always felt sick. And so I was labeled like a hypochondriac because I would go to the doctor and they're like, there's nothing wrong with you, you know? And I was always tired. And so I got this label of being like this like lazy hypochondriac. And it kind of followed me, not the laziness, but the tiredness. I was always tired and I could never explain why. And so as I got older, so one of the things I was always told, though, I was always overweight and I was always told to lose weight. And so as I got older, I was like, okay, I need to take control of my weight. And so as I started exercising, the fatigue and the pain got actually worse. Initially I was running and I was like, well, maybe that's it. Maybe, you know, the running's not good enough for me. And so, you know, I was reading all these journals and doing all this research and trying to figure out, okay, well, maybe I'm not, you know, running the right way. Maybe I'm not breathing the right way, you know, just really trying to get to the bottom of it because, hello, you exercise, you're supposed to feel better. And so it was really weird because I felt better, but I didn't feel better. It's kind of a real tricky, like, situation or feeling. It's really hard to describe sometimes, but so I just started walking. But even with that, with walking, I would get up really early in the morning because I knew that after I walked, I would have to rest for like an hour or so. And then I would get up and have to be ready for work. But, you know, just going through that, I went through college like that. I would fall asleep in class all the time. I was always a person always falling asleep in class. I would always have to take naps between sessions. It was just really a struggle getting through college. And so finally I was like, okay, wait a minute, this isn't normal. And so the first time I went to the doctor, I was 22 years old. And so I can say that first visit wasn't encouraging. I went in and so, you know, they did an EKG. And so in the same visit, the physician told me, he's like, well, maybe you're exercising too much. And I was like, well, I'm walking. Like, that's like the easiest non-strenuous exercise you can do. And then he was like, well, I don't know what to tell you then. He got really frustrated with me because I was asking questions. I was like, well, you know, trying to give out my symptoms. I'm like, okay, well, I have joint pain. I get fatigued. I get a little dizzy. I was really trying to get those symptoms to be recognized, but I was ignored. And so after that, I kind of went on just, you know, kind of visiting different doctors. And so finally, it started to get worse, obviously, as time grew on. And so I went to another physician and I was also having other issues too. And so in that visit, I was like, hey, you know, I'm having these symptoms. And at the time I was telling my mom, and she had gotten diagnosed with, they told her she might have a lupus or a touch of the lupus, which was weird, a touch of lupus, or that's what she said. But and so I was like, well, you know, I'm having all these symptoms. I described them to the doctor. I was like, my mom was told that she might have lupus. Could this be lupus? And the doctor just like almost went off on me. She's like, no, we see patients, you know, she's like, I practice geriatric medicine. I see patients with real problems, you know, so I'm not going to be running any unnecessary tests on you or whatever. And so I'm like, okay, I mean, that really hurt. And after that, I kind of lost hope and just kind of let it go. And so I think I was around like 28 at that time. And so time just went on. My symptoms got worse. Then I grew this pain in my side. So again, went to the doctor. I'm like, hey, I got this pain in my side. It really hurts right after I eat. And so the doctor's like, well, it sounds like, you know, gastric reflux. I was like, well, no, I don't think it's gastric reflux because it's in my side. My gastric reflux would be here, you know, in the front. And so kind of got blown off again. And at the time I was also having some gynecological issues. And so I went to my gynecologist and actually I got blown off for that too when I went to that particular PCP because I had this big lump and I'm like, what is this? You know, it ended up being a fibroid, but it could have been anything. But I was told, oh, you know, some people's uteruses are big or whatever. It was just ridiculous, right? So when I went to the gynecologist, he's like, yes, you have fibroids, but then he did just a basic CBC, which the previous doctors had done. he was like, something's going on with you. Your blood work isn't right. He's like, I want you to go back to the lab. I ordered some more blood tests. And so in my follow-up appointment with him, he's like, you know, something's going on with you. I said, yeah, I've been trying to tell people for years. No one's listening to me. So he sent me back to my PCP with a note saying to check me out. And that's when everything just kind of, the floodgates opened, right? I went back. By then, though, I had started to get so bad that all my lymph nodes were swollen. You could like feel them. So initially they thought I had lymphoma, had a couple biopsies, that was ruled out. Then I started losing blood. So then it was thought that I had leukemia, and I was tested for that, had a bone marrow biopsy, that was ruled out. And then some clots were found in my body because I still was having the digestive issues and the pain. And it was so painful that I couldn't even keep anything down. I couldn't even keep water down. And so I was diagnosed with, simultaneously, obviously, I was diagnosed with antiphospholipid antibody syndrome, which is a blood clotting disorder. I was also diagnosed with autoimmune myelofibrosis, autoimmune thrombocytopenia, pancytopenia, and portal vein thrombosis. Apparently, I developed a clot in my portal vein, which goes to your liver, takes the blood from your digestive system to your liver. So it was blocked, and the pain was coming from this pressure of this blood trying to get to my liver to be filtered. So after I basically went through all this, they were like, okay, you're losing blood. It's not leukemia. Let's make sure you're not having any type of bleeding, internal bleeding. So I had scans, like all kinds of scans. I had no shame during this time period. It was just like, okay, you know me inside and out now, it was just a crazy time. And so finally, after they made sure I didn't have any cancers or any internal bleeding, I was referred to a rheumatologist. And then it was, then I was diagnosed with lupus. So the time frame from me initially seeing the gynecologist and when I was diagnosed was from May to September. So, and I was 32 years old. So from the first time I went to a physician I was 22. And so then I didn't get diagnosed till I was 32. And then even when they knew it was obvious that something was wrong with me, it still took 6 months for me to get a diagnosis, because by that time, my immune system was just out of control. And so since my diagnosis, I've had to have a TIPS put in to bypass the clotted vein for my liver, which I had to get tested a lot. And then after I got the TIPS placed, I got an aneurysm in that spot, and I had to go back like a week later. Then I had a stent put in. I was recently diagnosed this year with Rose-Dorfman disease, which is another rare disease. I was diagnosed with stage 1 heart failure, but also they think I have a little inflammation, so that could be autoimmune related as well. So I always tell people I have lupus and friends, like autoimmune diseases like to come in packs. But it's been a challenging time, but I think one of the things that has gotten me through it is being a strong advocate for myself. That's what I realized. Early on, I wasn't as strong as an advocate, but after everything that I had been coming to the doctor about, everything, all the symptoms I brought, after those were confirmed and acknowledged, I knew, like, hey, I know what's going on with my body. I know I'm in touch. I'm not, just someone trying to get attention or just coming up with different types of symptoms. So I joined advocacy groups. I joined a lot of support groups. Even to this day, I am a patient advisor for adult medicine at U of M. I also started a employee resource group at my job for team members with chronic illness and disability, just so that we can get support in the workplace, because there's so many challenges, especially having lupus. The fatigue is, I think, one of the ones that really give me like the fatigue and brain fog. And so I advocate at work, even though, sometimes advocating at work can affect your career, affect how people perceive you. But I feel like if I can be an advocate for those at work who aren't as bold in speaking up, then I'll do that, because people need to know and people need to understand. And I think once people kind of get a perspective of what is going on, it really helps. And I think, I also participate with the onboarding of the first year med students as well, and really letting them know that, hey, sometimes, you might want to listen to a patient, because, blowing them off or not really taking their concerns seriously can have a traumatic effect or a negative effect on their life. I think if I was 22 years old and I was listened to and followed and tested, I probably could have gotten diagnosed earlier. I probably wouldn't have developed all those clots, wouldn't have had to have the stent plate. There's so many things that maybe could have been avoided if, a few simple tests were done. And so I think there's so many ways and so many avenues or whatever for advocacy and how to really get out there how this disease really touches you. I'm getting a little emotional too, because I'm coming out of a flare, and it just is it can be so discouraging when you have a flare. Like I threw a party, it was really great, but I overdid it. And overdoing it for a lupus patient obviously is a lot different than a normal person. Like a normal person can go set up a party, host the party, break down the party, maybe, sleep a little longer the next day or night, and then get up and they're okay. They may feel a little tired, but they recover fairly well. But for me, I was out for like 4 or 5 days physically, which puts you behind in life sometimes. I'm a single person, I take care of myself. So it was really, really challenging for me. And I do go to therapy because managing sometimes is hard, especially managing some of the multiple conditions that I have. Not just lupus, but this Rose-Dorfman is a new thing that I'm dealing with, and really trying to live life to the fullest that I can without making myself go into a flare. So it's very, I think it can be very challenging, but very encouraging at the same time, especially when I advocate or when people at work come to me. People at work come to me all the time like, hey, I was just told that I might have lupus. There've been people crying. I'm like, hey, let's go to this conference room. I feel like I do this side counseling. And if I can just reach one person with my story or encourage one person with my story, then that's good enough for me. It doesn't have to be this mass, thing. As long as I'm connecting with people and helping them get the diagnoses and the medical care that they need, it really is encouraging for me, and it helps kind of take the sting sometimes off of the challenges that can come with lupus. But I can say by far that even with all of the diagnoses that I have some diagnoses even outside of this, that I'm doing well. Of course, in my mind, I want to be a CEO, but I'm doing well. I can support myself. And, I have a relatively good life. And I think just working with your physicians, finding that support team really makes a difference in getting diagnosed with lupus and even living a full life with lupus, and even finding purpose in, I don't want to say purpose in having lupus, but finding a way to live a great life in spite of lupus. So that's pretty much the end of my my journey. Well, this leg of my journey. Obviously, there are more to come probably. But I would just want to thank everyone for having me and listening.
Thank you so much, Tiffany. I see some heart reactions from the audience. We're so impressed by you sharing your powerful story and, shining a light on, ways that, things can be better for Lupus Warriors, and the things that, have worked well for you and the way you've encouraged others, really, truly inspiring. If anyone has questions for Tiffany, please drop them in the Q&A. She can answer them live, or we'll follow up during the moderated discussion. So next, that brings us to Dr. Erin Stubbs' talk. Erin, are you able to share your screen? I'll let you introduce yourself and take it away.
Okay, I think it muted for 1 second. Okay. All right, my name is Erin Stubbs. I'm one of the rheumatologists at University of Michigan. And today I'll be giving the conversation on how diet and other metabolic risk factors like weight and things like that can have an influence on lupus. And I think this is an important conversation because, as we've previously talked about, many patients, once they get diagnosed, they may be told all the different medication options and other ways of treatment. However, many patients want to know, what can I do to really take my health into my hands, and what are some other ways outside of medications that I can have an influence on lupus? So we'll just give a background on how diet can influence lupus, and we'll talk about lupus's connection with the typical American diet, and then we'll spend some time talking about healthy diets that can be used for patients with lupus. So in terms of thinking about how our diet can influence lupus, I think the most important thing is to think about, dietary change. So what are the interventions that we can use? What changes can we make? Some of those changes would be low calorie changes, eating less calories. However, a lot of it has to deal with changing the types of foods that you eat. So for instance, increasing the amounts of anti-inflammatory foods and decreasing the amount of pro-inflammatory foods in your diet. And then finally, even with dietary change, with and without dietary change, weight loss can play a role as well separately. So in terms of what are the dietary habits of patients with lupus, it's very similar to the general population. So American patients eat a typical American diet. And what that usually means is that there is quite a bit of fast food consumption and sugary foods and snacks and fried foods as well. And many patients eat daily amounts of sweets and snacks. So what does this mean? So we know that there are many studies that have shown that fast food and fried food have a significant impact on the inflammatory process of lupus. And this can show up in symptoms as well as patients' labs. So there have been many studies to show that patients who eat higher amounts of fast food and fried food actually have worse disease symptoms. What we call this disease activity scores is what many of your rheumatologists will use in clinic, is where they calculate your disease activity. And but this is, in layman's terms, this is represented as symptoms such as arthritis, muscle aches and pains, fatigue, brain fog. And then we also have seen outside of that, even the symptoms that patients are having, you'll also see changes in their labs as well. We also found there have been studies to show that there's patients who have a higher frequency of meat consumption also have more lab evidence of lupus inflammation as well. So what are some benefits of eating a healthy diet? So many studies have shown that eating a healthy diet results in an improvement of depressive symptoms, sleep problems improve, fatigue improves, pain improves, as I mentioned, and also brain fog and memory issues can improve as well. And it's important to know that some patients will have an improvement of their symptoms through dietary change, while others may not, or it may not have it as on such a large scale. And this is why we definitely need more research in this area to determine what are the factors for making someone more likely to respond to dietary change, and which dietary changes are they going to have a better response with. So one of the major diets that you may see in the news, or even in articles that are published or talked about, or even something that your rheumatologist may talk about, is the Mediterranean diet. So the Mediterranean diet is basically a whole foods approach diet. You incorporate more fruits, vegetables, legumes, nuts, and whole grains, and a little bit of meat. And usually the meat is more fish and white meat, and usually reducing the amount of red meat that you eat. And there is also a higher consumption of omega-3 essential fatty acids. We'll talk about that a little later. And also increase amount of fish in the diet as well. So, and what they found with the Mediterranean diet is those patients who eat a Mediterranean diet generally have improved symptoms related to lupus, less likely to be obese, and more likely to have a better metabolic risk profile. So if you ever get your lipids checked and you get your cholesterol, your LDL, your HDL, and your triglycerides, that's one of the things that the Mediterranean diet can have an improvement on, which is something that we do think about as rheumatologists for our patients with lupus, because we want to make sure that we're thinking about the whole patient, not just necessarily their lupus symptoms, but also their cardiovascular health as well. So now I spent some time talking about the Mediterranean diet, but as you can see, there's a lot of overlap with many of the diets that are marketed. So some of the diets that you may be aware of is like South Beach diet, Mediterranean diet, paleo diet, raw food diet, vegetarian, vegan diets. And this is not a complete list. There's so many other diets. So which one should you focus on? And I think that's the big question. Which diet should I choose? I think the easiest way to think about this is thinking of a whole foods approach to what you eat. So focusing on foods that are whole foods and avoiding processed foods, avoiding fried foods, sugary foods, and foods with a lot of additives. So the difference with the Mediterranean diet is often there are different spices that are used, but the research is still ongoing in terms of if there are other foods with other cultural differences in how foods are prepared, for instance, with certain spices, for example. So it's not necessarily that a Mediterranean diet by itself is the best. It's just that we know that it has more whole foods and it has more omega-3 enriched foods. So I think the most important takeaway for what I explain to patients in clinic is you want to really just focus on eating whole foods, eating more fruits, veggies, whole grains, getting a handful of nuts every day, eating legumes, and just a little bit of meat, such as fish and white meat. And we'll talk about the portions for those a little bit later. So what is omega-3? So omega-3 is a fatty acid that the body cannot make on its own. And because we can't make it, we call it an essential fatty acid. So it's something that the body requires, but it has to be consumed. You have to eat it in your diet. And one of the more common omega-3 fatty acids is oleic acid, which is found in olive oil. And then there's also EPA and DHA, which is found in fish. Omega-6 is a type of very common essential fatty acid as well, and it's found in corn and soybean oil. Interestingly, though, this particular omega-6, this particular essential fatty acid tends to have more pro-inflammatory effects downstream. So even though it's essential, what we have found is that patients who consume a higher ratio of omega-3 to omega-6 have a better inflammatory profile. They have better symptoms, and they're less likely to develop progression of their disease, particularly with lupus, compared to those who have a lower ratio, meaning they're getting more omega-6s in the diet compared to omega-3. So this is just a table that just gives us an example of, okay, what do we mean by this ratio? Well, if we look at snow crab, for instance, you'll see that it has 61 milligrams of omega-3 compared to its 1 milligram of omega-6. So that's the ratio that I'm talking about, is that certain foods have a higher content of omega-3 compared to omega-6. And what we found is that those foods tend to be healthier for patients. And generally, patients who eat more omega-3s in their diet have better symptoms overall. And this has been found in quite a few studies, is that supplementing omega-3s through a nutritional supplement often results in improved symptoms. So particularly with lupus, there's numerous studies that show that omega-3 fish oil supplementation results in improved symptoms related to lupus, and also improvement of their labs, whereas a lower omega-3 intake was associated with worse lupus symptoms. I think that there's still a lot of ongoing research in this area. However, this is definitely something to bring up to your rheumatologist about whether you think that you should start, or whether you guys think that it would be a good idea to start an omega-3 supplement. So I spent some time talking about the different healthy food options that are available, but I think we need to recognize that eating healthy can be quite expensive. So I've listed just some resources, and these resources will be available on the Conquer Lupus website that can kind of assist with making sure that we keep in mind that getting certain foods at the grocery store are very expensive. Outside of that, though, there are meal delivery services now which are used more increasingly, especially in the last couple of years. And a lot of meal delivery services have started doing studies with more common diseases like diabetes and finding that patients, if they have a diet that's tailored to their condition, they are more likely to have improvements of that condition. So for instance, with diabetes, for example, patients who go on a meal delivery, a medically tailored meal delivery type of diet, they tend to have improvements of their A1C scores, which is a score that's used in diabetes. This has not been studied in lupus just yet or other autoimmune diseases, but it is something that we're interested in to see, is there a way that we can find, if we give a patient a couple of weeks of Mediterranean diet meal delivery service plan, will they have improvement in their symptoms and their labs as well? And so I think that this can be useful for patients who maybe have a hard time going to the grocery store, coming up with a recipe list on their own if they don't have access to a dietitian. Although a dietitian is also another excellent option, if you can, is to see a dietitian who can go over different recipes that you can try for healthier options. However, I just want to list this in case people wanted another option as well. So essentially, this is an easier way to look at how your plate should look when you are eating, preparing your meal. So then you have protein, and most of your protein you would want to choose, let's say, fish and legumes and nuts, and a little bit of poultry, and you would want to avoid processed meats and red meats. Red meats, particularly because they have a higher omega-6 content compared to omega-3s, and fish have a higher omega-3 content compared to omega-6. In terms of healthy oils, you would want to stick with olive oil and canola oil and avoid trans fats, and also omega-6 enriched oils such as soybean oil and corn oil. In terms of beverages, you would obviously want to stick with water as much as possible and avoid soda. However, tea is a very good option as well. For lupus, I will say that the jury is still out on coffee consumption and whether that is useful. So I would recommend drinking tea over coffee until we get more research in that area. So what about body weight? So we do know that for some patients with lupus, increased body weight can result in worse symptoms for lupus. And there have been studies that show that patients who are obese by the age of 18 are more likely to develop lupus. So we do know that there is a correlation with having a healthy body weight and the development of lupus and lupus symptoms. So I did want to just spend a little bit of time, not too much time, on just talking about basal metabolic rate. Basal metabolic rate is your body's baseline rate of burning calories, meaning if you were to do no activity whatsoever, this is the amount of calories that you would burn. It's important to know what this rate is because you can use it to help calculate what your calorie needs are for the day. So if your basal metabolic rate, which is dependent on your age, your sex, your gender, if you add that with the number of calories that you burn with activity, that'll let you know how many calories you can have for the day. So if your basal metabolic rate, which you can calculate, and that's also available on the Conquer Lupus website, if your basal metabolic rate is 2,000 calories and you burn 350 calories, let's say running or biking or swimming or doing yoga, then you know that you would have your calorie needs for the day would be 2,350 calories. From there, you can determine if you feel like you need to lose weight to get to a normal body weight. then you would need to eat less than the 2350 calories. If you are at a normal weight, you would want to maintain that calorie at 20 and just eat 350 calories a day. And I also want to spend some time just talking about the nutrition label. This is probably one of the most important things to understand when diving into nutrition, is making sure you understand how to read a nutrition label. So in terms of weight itself, if we're looking to lose weight, it really is calories in and calories out. So we want to focus in on calories more than we look at total fat, total carbohydrates, and protein. However, if we're also considering that we want to look at the content of the food that we're eating, we obviously want to avoid trans fat. So looking at the label and making sure that it has 0 trans fats, looking to see if it has polyunsaturated and monosaturated fats, which are better for you than saturated fats. And we want to make sure that we're reducing sodium in our body, because obviously increased sodium leads to a higher risk of hypertension and higher blood pressures. And obviously that can have a negative effect cardiovascularly for patients with lupus. We also want to make sure that we're getting enough fiber in our diet. Fiber helps out with absorption and digestive health, and it slows the absorption of food into your body. And then also we want to avoid any added sugars as well. So it is important to really make sure that you look at the nutritional facts of the foods that you eat to make sure that, is this a good quality food that you want to consume? And then lastly, I wanted to just go over, portion control and, making sure that we know how to look at portions from an easier lens instead of, just 1 cup, 3 ounces. I think an easy way is just to say, okay, if I need to get a cup of fruit, that's about the size of a fist. And if I want to make sure that, I'm not overdoing it with peanut butter or hard cheese, knowing that, it's 1 ounce is just a thumb size. But also, I want to make sure that we spend some time and just look at how the healthy plate should look, which is predominantly fruits, vegetables, and whole grains, and then a smaller amount of legumes and animal proteins. And so that means that not every meal should you have, let's say, meats such as fish and chicken, and you can sometimes skip animal protein for a meal for the day. It's not necessary that you become a vegetarian or a pescatarian. I think the importance is just to make sure that you're eating a whole foods approach to your diet. And that, any questions at all? Let's see if there's
Thank
in the
you,
chat.
Aaron, so much for that
No
great
problem.
presentation. We really appreciate you providing some clarity around, what does eating healthy look like, as well as, what's known but also unknown of the relationship between diet and lupus symptoms. So attendees, if you have questions for Aaron, please drop them in the Q&A. For now, he can answer them live. There will also be a chance to ask questions during the moderated panel discussion.
Sure.
That'll start around 11:40. Thanks. And so next, we have Dr. Mariah Moore, who will be talking about navigating healthcare, as well as the Conquer Lupus website that Dr. Stubbs alluded to earlier. Mariah, are you able to share your screen or unmute yourself?
It's not giving me the option to share my PowerPoint. It's like the whole desktop or nothing. So
I see.
see if I
One
can
moment.
figure out how to do that. I apologize.
How about now? Do you see an option?
Well, let me try.
You could also email me your slides, and you could just say advanced slide if that's
Okay.
if we're
That would be great.
other
I'll
options
do
will
that
work.
right now. Okay, I just said that, Rachel. So sorry about
Great.
that, everyone. Thanks for your patience. While we're getting that uploaded, my name is Mariah Moore. I'm a adjunct faculty at the University of Michigan, but primarily a clinical rheumatologist now in Columbus, Ohio, which was a change as of this summer. And I have a deep passion for hearing stories like Tiffany Stokely's, and I think all those stories and examples she shared with us can resonate with perhaps some of your own experiences. And I certainly have heard similar stories from my patients. And it doesn't sit well, obviously. We know that there are many things broken about our medical system, and there are definitely, lights and hope that we can glimpse throughout our journey in medicine. And I think you all are the experts in this area. But from a clinician's perspective, I just wanted to share some ways that I have seen patients be resilient and be able to take control of their medical care as much as possible. So that's what I'm going to start the first half, sharing some tips, a Lupus Warriors Guide to Navigating Healthcare, and trying to find ways to be an advocate for yourself. And if you are a friend or a trusted companion of someone who has lupus, I also have some tips for you too. And then the second half of my talk is going to be kind of focused on an exciting thing that we have been able to develop in partnership with our lupus community. That's I hoped to be a very helpful resource for you moving forward in your lupus journey. You can advance slide. So who is your care team? Most importantly, it's you. And I think that's important to, what you heard from the story earlier is that, there can be good and bad care experiences. Unfortunately, at some point, many people do encounter a bad experience, but I think that the constant in your life is you and how you respond to those interactions. And, moving forward through those experiences, moving towards interactions that are going to be more positive is crucial. And so thinking about
Here's what I found.
Oh dear, Siri wanted to talk during that. So you moving forward and surrounding yourself with positive people who are going to invest in you and your care and your success. And that includes your community, your family, your loved ones, your church community, your primary care doctor, specialists. So that might include a rheumatologist being your team lead, kind of your quarterback, but also nephrologists, which are kidney specialists, and potentially many more. I also think mental health is an important part of care. Being diagnosed with chronic condition often does take kind of a reframing of how you view your time, your pacing of your activity. And often it really helps to talk with a therapist because they can help you kind of reframe, how do I think about this? So that can be a really helpful resource, even if you don't feel like, hey, I have a diagnosis of something related to mental health. It can often be a helpful way to cope and develop strategies for how to kind of progress through this kind of stressful situation. Social workers and case managers can be helpful resources in terms of thinking about the financial aspect of medical care, which can be an important aspect, important source of stress. Patient advocates are available in most hospital systems, and those are people that go by many names. Ombudsmen are one name. Ms. Stokely is a current patient advocate, serving on a board that helps to provide medical training for medical students. So that takes many forms, but I think it's important to know that most hospital systems have someone in that role, and what they can do to help is really provide kind of options. So say you encounter a bad situation and you're wondering, well, what are my options? This doesn't sit right with me. What can I do about it? How can I communicate about this with my care team? Or maybe I need to see a different doctor. So just kind of telling you options, which I think can be very helpful. There are at-home care options. So people who've been hospitalized often, need additional assistance after they leave the hospital in terms of rehab, but there are also at-home care options that you may want to look into if you're having difficulty with function. So things like help with activities of daily living, which include things like cleaning, bathing, sometimes meal prep. And there are agencies in each community that have kind of lists and databases of those resources. And sometimes those are linked with, Medicaid, Medicare. And so I just want to kind of provide an umbrella overview of that there are some of those resources available. And then rehab. So occupational therapy, that's often helping folks find ways to adapt to maybe limitations that your body has for you at that moment, to still do the things that you need to do and want to do, finding ways to adapt your environment to support that. So sometimes they do home visits, sometimes they will just do office visits to talk to you about well, how do you knit now? Or how do you stir if you're having arthritis in your hand? Physical massage therapy can be adjunctive types of options for you. And then speech language pathology is sometimes helpful in folks who have difficulty with brain fog or speech related to difficulties with inflammation. And then I list chiropractic care. I think always talk with your doctor before you proceed with chiropractic adjustment in case you have arthritis in areas that might be harmful for you to get adjusted. So just other avenues some people find relief. Could go to next slide. Okay, so how do you find a doctor? Sometimes it's dictated by your insurance. So that's a starting place that some people find success in terms of the financial limitations and restrictions. Asking for recommendations, communities like this, the advisory boards that we, have many active participants in, those can be good resources for finding recommendations. Logistics certainly matter. So learning about, when are they open? Do they have weekend hours? Do they have early appointments you can get to before work or after work? Just the ease of access, all those things really do matter. So when you're calling to talk to them about making an appointment, learning about those restrictions. And primary care doctors, I just wanted to point out that family practice and internal medicine, they both provide primary care. So, but they have a little bit different scope. Family practice often offers things like OB care or pediatric care, whereas internists primarily see people aged 18 and older, but may have a little more expertise in some of the, kidney care, heart care, lung care. So I wouldn't say one is better than the other, but sort of depending on where you are in life and what your preferences are, might dictate your choice of a primary care doc in either of those categories. And then I included some places you might go online to look for a rheumatologist. Both Lupus Foundation of America and the American College of Rheumatology have resources for how to find a doctor. You can go to the next slide. So now you've got your appointment on the books. What should you be doing to try to make the most of that time? And I think I have a lot of patients who find it helpful to sit down and write through, a story of what they've been experiencing. So from the beginning, kind of how things started. That helps you to kind of synthesize like what you've been going through. And then kind of reflecting on that journey that you've been through to that moment. Pick the key kind of symptoms that you're like, wow, these are my top 3 things that I feel like they're just really affecting my function, my day-to-day. And that can help your doctor hone in on what's most important for you. Sometimes I think people apologize because they feel like, oh, this is just way too much. I feel like I'm going to overwhelm my doctor. And I would say, don't second guess yourself. Trust your body, trust what you've been going through. But I do think it is helpful if you are able to really try to hone in on the things that you feel like are most significant. And that allows, I think, your doc to best use the time that you have together in order to prioritize what to address first. And so what to bring? So medical records, as many of you might know, are sometimes different depending on what system you're in. So bringing a copy of any prior records that you have access to can often be pretty helpful. Bringing lists of diagnosis, of current medicines, of allergies can also be super helpful. And often you will have an opportunity to input that into your record before your appointment. So if you can do that, that's really helpful. And then scheduling regular appointments. Sometimes it's great if you are able to try to schedule several in advance. Just that way, you know, you've got that on the book and your doc is going to be able to see you. Some docs fill out even 5-6 months in their schedule. So that can be a helpful way to make sure you're going to be seen regularly. And then track your symptoms. So some people find writing a journal of their symptoms between appointments can be helpful. And I'll show you another option here in a minute that you'll be able to do that. And finding someone to help you advocate for yourself, bringing someone you trust, is a really crucial part. And we'll talk a little more about that in a minute. Next slide. So some logistics for appointments. Bring the essentials. So having the contact info for that specific doc is really helpful in case you're running late. You need to call in and say, hey, I'm going to be there in 5 minutes. That way they have a sense for what's going on. We talked about bringing a list of meds and allergies, having some water with you or a small snack in case the doc is running behind, which often does happen, so that you're not kind of stranded. And any needed medicines that you might be taking through the day, make sure you have those with you. And obviously something for you to entertain yourself during the wait. It can be really exhausting going to appointments. So something that can help kind of ease the stress and the wait. Navigation. So, University of Michigan is a big system. So, getting there, finding transportation, parking, and then finding your way inside the building for the first time can be a lot. There usually are people around to help. But if you are able to get there beforehand so that you feel more comfortable on the day of your appointment, that can be a big help. And then the support piece, I can't underestimate enough. Having a trusted companion with you just to help ease that stress of the day is a huge piece of it. There are resources for transportation to appointments. Some insurers provide that. And then looking into like local groups, sometimes there are transportation services that either at no cost or very low cost. Some options for that include like area agencies on aging. There are many others though. Community health departments might have also databases, and those can vary depending on where you are in what community. If you speak another language, there are language interpreters that are provided to help assist with the visit. And then at any time, you are also allowed and encouraged to ask for a chaperone so that you feel comfortable with any exam that might be done. And that's completely normal and expected if you would like that. Next slide, please. So during your visit, share the information that you've gathered. Don't feel like you're too much. Your story is your story, and don't shy away from sharing it. Take notes if you are able, or ask your companion to, because there's often a lot that goes on in that visit, and it's helpful to have that written record for yourself and moving forward, just kind of for your own kind of progress as you've tracked through your journey. Sometimes I've had patients ask to record your visit. So bringing in like on your phone or an actual recorder. I will say, I think it's best if you can ask your doc if they're okay with that. Some docs might be uncomfortable for whatever reason. But I think, if you have difficulty with brain fog, or you just want to have a good record of your visit, it's reasonable to ask. I think most folks would feel okay with that. And just obviously empowering you to ask what questions you might need. Ask clarifying questions. Ask them to explain the jargon that they're using. Get it in writing, be brave, and then work together. Next slide, please. So as you heard from Tiffany's story, it can be really difficult to trust when you've had negative experiences, potentially bias, that can make it difficult to engage with medical providers. So having a companion there who could advocate for you or say, hey, what do you mean by that? Or, hey, did you hear, that her symptom is this? What do you think about that? That can actually help you to kind of take the pressure off. And it can help to share requests and concerns up front. So, there have been some work that's been done that's shown if you are cared for by a person who's concordant with your identity, either that's race or ethnicity, or, certain preferences in that way, that can help you to have a better sense of conversation and trust with your medical provider. If possible, I think it's very reasonable for you to ask this. This is your care, so you should ask for those things if possible. May not always be possible, but I think it's a total reasonable thing to ask for if possible. Next slide, please. So after your visit, so keeping your records all in one place is very helpful. Making sure you've got your plan written down and have a sense for, what are the next steps, what kind of imaging is going to be done, what testing do I need to have when, and then understanding if this is the right fit for you. You may have bad experiences. It's totally reasonable to say, hey doc, this was not really okay. Is there something we can do differently next time? Trying to reframe it as an action so that things can change for you, that you don't have to dread a bad experience every time you talk to your doctor. And utilizing your medical record, many systems have portals. Sometimes you have access to what your note is after the visit, and that can be a helpful way to know what your plan is. Next slide. And then creating a flare plan. So recognizing what your triggers are when you have a flare, and then ahead of time, before you have a flare, know what the contact info is for your doc. Do you need to have any urgent visits or testing done? Know what medicine options you might have available to you for your flare. Know what to do at home to adjust your activities, if you need to rest, heat or ice, kind of create a plan so that it takes the stress off of that in the moment, what to do if you're having increasing symptoms. Next slide. And then if you are a loved one or a companion of somebody who has lupus, be their advocate. Talk to them ahead of time about what you can do to help. Don't assume that they necessarily will want you to do certain things, but let them know that you're there for them and that you're willing to do things if you can and if they want you to. Know what their signs of a trigger may be, and try to help them avoid things that may trigger a flare. So help them to, say they are about to overdo something. Ask if you can try to take some of that work off their plate. So those are things you can do to help advocate for them so they can reduce their frequency and severity of flares. And then help access care. So know who their docs are and the contact info. You may need to sign up as an emergency contact or have a healthcare proxy if that's what that your Lupus Warrior wants. And offer to assist with transportation if you can. Next slide, please. So I'm really excited to share this resource. So this was created for patients with lupus and for their trusted companions and caregivers and friends and family. And it is conquerlupus.com, and it is now live as of this week. And this was created in partnership with people with lupus, Lupus Warriors. And these are 2 Lupus Warriors who are essential in the creation of this website, but there were many others. And so this is a resource that you can go to learn about lupus, learn about triggers of lupus, learn about medications, vaccinations, learn about then what you can do at home with your community to avoid triggers, things through diet, things through activity to reduce your symptoms and actually thrive with lupus. Next slide. And here's an example taken from this site. So going through, what kind of symptoms people with lupus can experience, some of which are, related to disease activity, some of which are kind of a result or maybe a symptom of lupus, and things that you might be experiencing, things that you might want to do about it, either with your doctor or at home. Next slide, please. Here's another example of understanding things that might trigger a flare. And each of these have more information about how that can cause a flare, and then things you can do to try to avoid it. Next slide. Information about how to engage with your doc, options for how, if things aren't going well, what you can do to try to improve that situation. Next slide. And then there's a whole section on, if you're a friend or family member of someone who has lupus, what can you do to really support them? Next slide. And then I did mention earlier, there is a way you can actually track your symptoms. You'll have a unique login to you, and that will allow you to go in and track, day to day, or however frequently you'd like, how my sleep is going, how my pain is going. There's a section about, physical activity as well. And then that will allow you to kind of correlate, changes in these things may seem to correlate with worsening or improvement of symptoms. And I think that empowers you to have a better conversation with your doctor. Next slide.
I think that's the last slide that I have. Yes.
Great.
Thank you so much, Mariah. Yeah, we're so excited for the launch of the Conquer Lupus website. It just went live. It may have been just today. We've been working very closely to the wire so that would be ready for this conference. So we encourage all the registrants to visit that when you have time. I'll add with that symptom tracker, you do create a login, but that data is private to you. No one accesses that data. It won't be used by anyone else. It's purely for your purposes so that you can kind of inform your care plan and use it to talk with your doctor. So with that kind of closes the initial part of our agenda. And so we have a few minutes for the moderated discussion. So I invite all the panelists to turn on your audio and speakers and cameras. A lot of the questions were answered live in the Q&A chat. There is one that we can start with asking about the pandemic and COVID and lupus and kind of what are recommendations for warriors in their day-to-day lives, as well as maybe some, if there's any tips around, the vaccines and like some of the boosters that are now available. Michelle, do you want to get us started?
I'll just make a note. I don't know if Erin's replies to the patients got put into the Q&A because I see them in our chat, and I don't know if you want to copy.
Yes, I let him know, and it looks like they're in there now. But why don't we revisit those questions too? Because I think they do cover some really great points about the diet. Yeah. So we'll do that next. Thank you.
Good. Yeah. So with COVID, it changes every week. So I'll tell you kind of where we are right now. And then, I think it's really important for patients to stay in communication with their doctors because every patient's medication regimen is different and their risks may be different depending on if they've had kidney or lung disease in the past. And so it's really hard to make a global lupus recommendation. But what I will say is that for the most part, the current strains of COVID that are circulating are in this Omicron family. And for the most part, these have not resulted in nearly as much hospitalization and severe illness as what we saw with the original and then the Delta strains of COVID. We know that our vaccinations are very good at preventing severe disease. It doesn't protect you from getting infected, but they're pretty good at keeping people out of the hospital. And the new Omicron specific booster seems to also be providing that and also seems to be increasing antibody titers very well. There was a study last week that showed that the antibody titer responses were very high in patients who got the new bispecific booster. And we know that titers of antibodies correlate with protection. And so I think everyone should be getting the booster as long as, you haven't had allergic reactions or other, significant issue with the vaccinations. The other thing I'll say is that if you've had issue with the mRNA vaccine. There is now an FDA approved vaccine that is sort of the old school vaccine, which is a recombinant protein vaccine, just like the tetanus shot. And that one also has an approved booster regimen now. So if you don't want to get an mRNA vaccine, we do have traditional vaccine options now for COVID that also offer the same protection against severe disease. So you should talk with your doctor about whether that would be a good option for you. And the other option that's out there is Evusheld, which is not a vaccine. It's actually antibodies that protect you against severe COVID. And these antibodies are given through a shot. Basically, there's 2 injections that you get right at the same time. And these antibodies basically do what a vaccine would do, except that they don't have any activating effect on the immune system. So it's very similar to like if you get Benlysta, or if you get another drug that is made of antibodies. It's just giving you the antibodies. And we were using these same antibodies to treat COVID for the first, year plus of the pandemic. And so these antibodies have been very good against the BA4 and BA5 Omicron strains. It looks like there is now a strain of Omicron that is more resistant to these antibodies. For now, it's not prevalent enough, and they might have to switch up what's in the Evusheld if the resistant strain becomes more prominent. But right now, we're still recommending Evusheld, and it gives you 6 months of protection. So if you're somebody that doesn't want a vaccine at all, this is a way to get some protection against severe infection. And for BA4 and BA5, it was actually protecting against infection pretty well. So Evusheld is another option. So I think, what I tell my patients, and again, every patient has different risks, is that COVID isn't as scary now as it was when it started. We have ways of managing the infection. We have drugs like Paxlovid, which can help keep the severity of the infection down. And so, I don't think people should be hiding in their houses and like not living their lives anymore. But still, taking precautions, masking, asking your friends around you to mask is always a great idea, just to avoid exposure. But it's at some point we're going to have to live our lives, and the Omicron strain is probably what's going to be hanging out. It's had really strong staying power for the last year. And so, again, exceptions to everyone. If you're in the middle of Cytoxin, maybe going to a rock concert is not the best idea, but, for the most part, I think we have really good ways of preventing people from getting super ill. Vaccines, Evusheld, and then if you do get COVID, Paxlovid is a good option. Just I'll put out there, if you do get prescribed Paxlovid, you should hold your Plaquenil while you take it, because Paxlovid has a lot of medication interactions, and Plaquenil is one. And so you should just not take your Plaquenil while you're on the Paxlovid to avoid the interaction there. But yeah, I hope that answers the question.
Great. So there's another question that came in that we'll get to also, but Erin, if you just kind of want to review some of your comments in response to the questions people had about diet, and I saw coconut oil versus coconut milk.
Yeah, so the first one I'll talk about is coconut oil. I would actually recommend at this time not choosing coconut oil as a go-to for being anti-inflammatory. I would actually prefer to or recommend that people would choose, let's say, olive oil over or canola oil over coconut oil. It doesn't have as much of an omega-3 content, which is one of the things that we spent a little bit of time talking about, is the importance of omega-3s. It does have more saturated fats. However, jury's still out on, if coconut oil saturated fat is the same as other saturated fats. So at this time, I wouldn't recommend going towards coconut oil. If you were trying to be healthier or choose a healthier oil, I would pick olive oil or canola oil over that. And then also the other question was related to organic foods. Absolutely. If you have access to and can get organic foods, I would recommend that. And that was actually something that we wanted to study specifically for lupus patients. However, we do know that with organic foods, you're less likely to have pesticides and other additives, and we do know that there is a connection with pesticides with certain certain autoimmune conditions in terms of it being an environmental risk. How important that is still, the jury's still out on that. However, I would say especially with meats, organic foods, organic meats are I would recommend those as well. And so and that was actually another aspect of that is, let's say if you're talking about grass-fed or grain-fed meats, I would recommend grass-fed because more than likely they're getting a higher omega-3 content. So you could potentially get from your red meats, you could get more omega-3s in those red meats if they're grass-fed compared to if they're not grass-fed. So, but at least for right now, yes, if you can choose organic foods over non-organic foods, you should.
Great, thank you. I see another comment from my guest saying, my daughter is newly diagnosed with lupus, but it hit her hard, hospitalized for 2 months and now home with foggy and mental concerns. Tiffany, I was wondering if you had any tips or advice for someone getting out of hospitalization related to a flare, or Mariah, if you have tips on navigating, supplemental care for mental health. Tiffany, we'll start with you.
I would say with the brain fog, I would say the best support you can give is to be compassionate and to believe that, yes, she can't remember. Like I had a party and one of my friends, I totally forgot her name. It was gone. Like, so, and I'm like, and I just say brain fog, I'm at the point now where even at work, I'm like, brain fog, there'll be times where I'll forget people's names. I'll forget things that I've known that I know, so it does hit, especially during a flare. It can be really, really bad. So I would say be supportive, be compassionate, and it can, especially being newly diagnosed, it can be a little depressing because, like, for me, I was always witty and always quick and sharp. And so to go from being this quick, sharp person who could catch on to things quickly and then moving to someone who, like, wait a minute, what was I doing? That transition was hard. So if she's willing, I would definitely say counseling or therapy is great. And I see a therapist now, shout it to the rooftops, because they are an unbiased third party. They're there to help reframe and listen, and they're trained to help you, so I think there are times where, like, that's who I go to. I'm like, hey, sometimes I'll even ask for extra sessions. So, because to get that support and that safety, comfort. So those are the things I would recommend. If she's open to it, going to counseling or therapy, and then also just being supportive and believing what she says.
Thank you. Mariah, any comments you want to make about kind of navigating healthcare, getting care for some of these symptoms?
So the website does have a section about brain fog, and it has some resources for folks who are dealing with that symptom. I think given how new this is for her, as a caregiver, as a loved one, it's a tricky balance. When you're noticing those things, I think it can be almost a little more harmful to point it out or to make it a big deal or to emphasize it. I think focusing on memory issues can often make it more frustrating for the person, or I'm not saying dismiss it at all, but certainly validate, support, but emphasizing or focusing on that as being a harm or a problem is often not helpful. And so instead of, pointing it out, I'd say, just find ways to unburden them if you can, find ways to, reduce their task list for that day, providing them extra time to do things that they need to do. Don't rush them, making situations as unstressful as possible, because stress compounds brain fog, compounds if you have difficulty remember something and then you feel bad about it and then you feel stressed about it, that compounds the difficulty of your cognition. So just trying, I think, to not emphasize it, but also try to relieve the stress that surrounds those episodes of brain fog and difficulty, using the website to find help and resources. So yeah, absolutely, like therapy, I think, is a great way to try to recover in terms of reframing and stress reduction that surrounds brain fog. But also there's speech therapy is one resource I've had some patients find success with in terms of evaluating your memory and cognition. I think most folks don't quite, meet a criteria for, having a memory issue. It's more just, with flares, with those episodes of inflammation, your body is just more burdened and your energy stores are zapped. And so, of course, your cognition is more difficult in those episodes. So I think those are some recommendations I have.
Can I
Thanks,
make one
Mariah.
other
Yes,
point?
please.
And, because your daughter just got out of the hospital, this is the hardest time. So I'm sure she's on a ton of steroids still. Like typically, when somebody has a major flare that required her to be in the hospital for that long, my guess is she got pretty aggressive medical, treatment to get her lupus under control. And when those steroid doses are high, that's so hard. Not only do the steroids make you, gain weight and feel bloated and, make your stomach upset and all these things, but they can also compound the mental health issues, because they can also make you feel more depressed and anxious, and they make your sleep terrible and all these things. And so, there's not a lot counteracting all the side effects of steroids are hard. I think having conversations, when can I taper steroids? Is it safe to taper steroids? Like that's always something to ask every time you go to the visit. And I think the other thing is we just have to realize that how the lupus is today is not how the lupus is going to be in 6 months. And I think thinking about that light at the end of the tunnel and getting through the steroid taper and onto more stable, less toxic medications is the goal. And, in 6 months, things will be much better. And so it's a really hard time after a really severe flare, and just, try to help her find some hope too, that she's not always going to feel this bad.
Thanks, Michelle. Yeah, I also want to point out the potential of getting connected with patient advocacy or patient support groups. I know Lupus Detroit hosts one regularly. The Lupus Foundation of America is another way to get connected with those too. We're close to time, but I do want to finish up with one more question because I think it's important. Another guest writes, I just want to say thank you for this wonderful conference. I learned something from each speaker. Tiffany, God bless you. Thanks for sharing your story. But the last topic or question I want to touch on is pregnancy. What medications are safe during pregnancy? How can people plan for successful pregnancy? Maybe even dietary recommendations around that too. So whoever wants to get us started for this.
Well, I think number one, you'd never want to get pregnant while you're in the middle of a flare. So all the data points to really wanting your lupus to be well controlled. And by that, it's sort of our medical definition of well controlled, right? Like your labs look okay, you don't have active organ inflammation. It's not that your fatigue and some of the other things with lupus are perfect, but we really want to make sure at least the active inflammation is quiet, because then the data supports that lupus patients, have a much better chance of a successful pregnancy if we go in with a nice quiet lupus activity level to start with. So I think number one is that. Number two, if you can tolerate hydroxychloroquine, all the data points to staying on hydroxychloroquine during pregnancy. It decreases flares. If you do have some high risk features like anti-Ro antibodies, it does seem to have some protective effects against some of the things that those antibodies do, like heart block in the baby, neonatal lupus. So you definitely want to stay on the hydroxychloroquine. And then third, before you get pregnant, you want to establish with a high risk OB, because these appointments can take a while to get. And so if you know that you're going to be pregnant, it's good to meet with them and talk about, your individual risks for pregnancy and, what unique things about your lupus are going to impact, how you're monitored while you're pregnant. And some patients have weekly visits, the last half of their pregnancy. And so, and it's annoying, but we do it to make sure that the patients are as safe and healthy as possible. So I would say pre-planning, getting a high-risk MFM, which is a maternal fetal medicine specialist who's really good at dealing with issues with baby and mom, and getting a team in place before you're pregnant, and then making sure that your lupus is quiet and you're on hydroxychloroquine, plus whatever other meds you need. Usually Imuran is the other immunosuppressant that's safe in pregnancy, or tacrolimus. You can't take Cellcept. You can't take any of the new biologics during pregnancy. You cannot take some of your kidney medications and blood pressure medications during pregnancy. So it's really important that you have a conversation with everybody involved, so that when you get pregnant, there's no toxic meds on board, your lupus is happy, and you've got a whole team to surround you and monitor you to make sure that you get through it with flying colors. So
great, thank you. Erin, any comments on kind of the diet or caloric intake during pregnancy that you want to add?
Yeah, I would. The main thing that I would say that you want to watch out for is don't try to lose weight during pregnancy. No matter what, you still will need to gain weight. So that wouldn't be the time to try to go on a weight loss diet. You still want to try. So this would be one of those differences where we're talking about dietary modification versus weight loss changes. So you still want to change your diet to a healthier diet with anti-inflammatory foods, like we discussed. However, I think one of the big things that we definitely should stress is you don't want to try to lose weight during pregnancy.
Great, thank you so much. So with that, we'll close today's conference. Again, I just want to thank all the guests for attending today, spending your Saturday morning with us. Thank you so much for the speakers for sharing your expert input and advice and stories. Thank you, Kiana, for helping to host this meeting and solving all the tech issues in the background, making it a very smooth experience for our audience. We are available if you have questions. A few emails were shared, but please reach out to us. If you do have follow-up questions, we'd be happy to answer them. We recommend that conquerlupus.com website. Please check it out, and have a great rest of your day. Thank you.
Thank you.